Well, the interview that I had with Dr. Nicholas Crisp, who's the Tsar, if you like, of South Africa's National Health Insurance Project, has evoked a lot of response, not least from the Free Market Foundation, whose chairman of its health policy unit, Michael Settas, is with us today to give his right of reply and maybe give us some alternative thoughts on it. Michael, thanks for joining us. We do believe in having all sides of every argument. It got us into a little bit of trouble during the COVID period where people got terribly emotional. But if COVID was an emotional subject, my goodness, this national health insurance in South Africa is, as much as people are very set on whether they want it or don't want it. From your perspective, just your day job, what do you do outside of working with the Free Market Foundation?
Yeah, I do. I've been in the healthcare industry. Thanks for having me on, firstly. I've been in the healthcare industry for most of my working life, so that's about 3 decades, probably why I've got all this grey hair, but including the NHI. But I've mainly worked in the private health sector, and I currently have a partner in a business in which we provide health insurance to people.
So it's your game. This is your game. This is your business. This is your area of expertise.
Yeah, I've been, I enjoy it. I mean, to the extent that it's a very interesting sector, private and public.
It's also a sector, and that's why we've actually, on our side, as far as health is concerned, we've been a little bit cautious because it is highly contested with different ideas. Some people saying big pharma is bad, other people saying big pharma saves lives. And because their lives at stake, we've said, we're going to withdraw from that area to a large degree. But you can't withdraw from the national health insurance debate. This is affecting all South Africans' lives, and it could be some big, big tax issues coming down the line. Just as far as the Free Market Foundation is concerned, I suppose we can assume what your position would be, but maybe you can outline it for us.
Yeah, I think South Africa has already in both the public and private sectors, we've got quite a substantial health system. One of the things that has been an interesting aspect of this whole policy is that it's been requested that it's been put forward that we need this in order to attain universal health coverage. But the actual fact is that we already have that. The World Health Organization, the International Labour Organization, as well as the Health Market Inquiry, all quoted us as having universal health coverage. So our framework is there to achieve it. The issue is mainly the cost in the private sector, which it has over the last 2 decades experienced very high cost increases. So it does make it unaffordable. So it needs some reform there. In the public sectors, obviously, we all know about the quality issues there. We know that you just need to read the press and, you know kind of what's happening. And there are lots of problems there. But these problems, and I think where we differ in terms of what the narrative has created is that the public sector problems are a governance issue and bad management. It's not a resource constraint. We may not necessarily as a country have, as many doctors as we need, but then there are very few countries that do, so we have to work with what we've got. But, if you look in the public sector, there are more doctors to a ratio of doctors to patients now users than there have ever been in the public sector. In real per capita terms, the health budget is double what it was 20 years ago. So resources have grown very substantially in the public sector, but we see the failures, the constant failures. So we're arguing, and the NHI is arguing that they want even more resources than what's already been given into the public sector. So we're arguing you could throw as much money as you want at this. It's not going to fix it. You have to fix the core, and the core all lies in governance and management. So that's really where it is. And in actual fact, the Office of Health Standards Compliance, which is a department within the division within the Department of Health, you could almost consider them a clinical auditor general, if you like. They audit, but they do it all around the clinical aspects. They themselves have highlighted that the weakest component in their inspection reports is governance and management. So government itself has told itself That's the problem. But doesn't suit the NHI narrative, unfortunately.
Well, and perhaps that's the way you're reading it. What I read from Dr. Crisp's interview, though, he said the structure's wrong. We need to restructure. He says that, for instance, the hospital superintendent or chief executive of a hospital hasn't got control over many aspects of running that hospital. If it needs to repaint, for instance, you have to get hold of Public Works Department to come in and repaint. So the structures, according to him, were wrong. He also added in fact, I guess would agree very, very strongly with you, certainly from the chat that I had with him, that many of the managers of these hospitals, on the one hand, they don't have the authority, but on the other hand, they don't really have the competence, because we've had CADAP deployment and those kind of issues. So governance does appear to be high on the list for both him and you. But where do you differ most strongly with what Dr. Crisp has to say?
I think the issue is that, we have to go back and, with all respect to Dr. Crisp, he's being tasked with, implementing this and managing them. So he's the builder. I think where we've got the problem is the architect, how this thing was built and designed. And that, I think, is really where the issue lies. He's got it right in terms of some things like, all the maintenance and the building of hospitals and the repairs and all those things, all done through the Public Works Department, not through the Department of Health. So that is an area where I would agree that they really need to either get Department of Public Works, up and get them to a level where they're doing what they're supposed to be doing. But by all accounts, they're not. Or alternatively, bring that budget into the Department of Health so the Department of Health can manage its own maintenance. So it actually is in charge of its own facilities, because it is a bit of a disconnect at the moment. That is two different departments that need to implement these things. And then what you tend to find is that between them, they blame each other. So then it just turns into a blame game that, they're pointing fingers and not really getting down. Charlotte Maseke Hospital is a perfect example. I mean, I can't remember, I think it's a year and a half now since that fire there, and it still hasn't been repaired. You're going, it's just insane. I mean, it doesn't make any sense that these things don't get done.
So where do you differ primarily with the narrative that Dr. Crisp is promoting?
Yeah, I think, there's so many things. I mean, I think, the institutional design that NHI is bringing is a massive reorganization of both the public and private sector simultaneously. It's a very, very high-risk proposal. And on top of it, there's been no feasibility studies, no technical feasibility understanding of how this thing's going to operate. The institutional design hasn't been tested. And, given that the magnitude of this, it's two very large sectors of the economy, our view is it's quite reckless to actually plow down with this thing without having done the feasibility understanding of how it's actually going to all get together. And the sort of idea, the narrative that we'll just sort of, plug it together as we go along, I think that's asking a lot. The other side of it as well is the rearranging of additional taxes and financing. If we look at in the latest SARS tax report tells us that nearly 80% of personal income taxpayers claim a medical tax credit. In other words, they're medical aid members. Okay. So what we have is virtually all the healthcare funding in the country is funded by the narrow base of taxpayers that we have, because they pay their medical aid contributions and they pay their taxes, which finance the Department of Health. Now we're saying that to those very same taxpayers, we're going to take away your access to private care, and we're going to increase your taxes as well. It's fiscally, I think, very dangerous. We could be seeing an even further narrowing of the tax base, which then has massive financial implications. And none of these have been tested. There's been no assessment on the fiscal feasibility of this to raise. The white paper said about another 3.2% of GDP. We're looking at nearly 200 billion extra in taxes. It's a massive increase. And in simultaneously to take away your ability as a private citizen to access your own private care. I think it's very, very dangerous policy.
The argument that comes from the other side is that in national health systems around the world, and I did have the chance to talk to Dr. Ali Gufron Mukti, who runs the Indonesian healthcare system. There, the percentage that is put into healthcare, if it's all consolidated, is far, far lower than when you have a fragmented system like we have in South Africa. Here, Dr. Crisp was saying we spend about 8.5% of GDP on healthcare. In Indonesia, their healthcare, national health, is under 3%. And if you get sick, you can go to a pharmacist and you get your medicine for free because of the consolidated system that they have. Now, there's a heck of a lot of complexity behind all of this, but it seems to be the argument is we aren't getting value for money anywhere in the healthcare system. His another big argument that Dr. Crisp gives is that the administration costs amongst private healthcare companies or medical aids is 15%. And if you start looking at that as a takeaway from the national budget, if you like, on what we should be spending on keeping people healthy, it seems like a very, very big number, especially when you compare it with Indonesia. But are we looking at apples and apples here?
Yeah, look, I mean, the one thing that is very, very difficult to do is compare national health systems, because you can go and look at 10 different countries and you'll get 10 different systems. It's very difficult to make the comparison. But in terms of what you said, like an Indonesian system, which I'm not familiar with, but you said anyone can walk into a hospital, go to a pharmacy, get treatment. But we already have that. Every citizen in this country, in fact, not even citizens, but every person in this country, because can walk into the public health system and access care. It's just the quality of the care that's become a problem, or with, the actual delivery is failing, but the accessibility is there for everybody. So we're not really talking about people being denied care, they're being denied quality care. And that's really the issue. I come back to that point is it's not about a lack of resources. We look at all 51 upper middle income countries, of which South Africa is one of them. The average public health spend is 4.1% across all 51 countries. South Africa's average is exactly 4.1%. We're absolutely in line with our peers. We're not out of line. Looking at the private and adding it to the public and then saying we spend too much, to me it's like, then you might as well say, we're going to go down the road of a Cuba communism, socialist state, because you're going to nationalize everything and say the state must run everything. I mean, it'd be like if you looked at what people spend on cars, so wealthier people can buy, more expensive cars. Do you now say, okay, well, you have to take that right away as well? It's an ideology that you have to sort of get around. That yes, people who have the money to buy better healthcare will buy it. But what are the implications of taking that away? I don't think it's a clear cut. I don't think it's not quite as rosy as it sounds. That we'll just take the money out of what's being spent in private, put it into the national health insurance, and then everyone will have fantastic healthcare. I don't see when you amortize the spend of private across the whole country. Remember, it's only 9 million people in private. If you amortize that across 60 million, you're not going to get anywhere near to the level of care that's currently available in the private sector. So you're definitely taking a very substantial chunk of healthcare access away from those people who currently have it, paying for it for themselves. And also on a fairly spurious argument that you can now raise the same amount of money through taxes as what is being spent in the private sector now. And none of that's been tested with any sort of assessments or analysis, any feasibility, understanding of whether that. I mean, many economists are saying it'll be impossible to raise that level of taxes. And then what? Then you actually just back to square one. You've done nothing.
I'm really confused here because that's not what he said to me. He didn't say that we're taking away from the private sector or closing private hospitals or chasing doctors away. He said that if you were to have a basic level of care that does not exist at the moment sure you say it does, but if I want to go and get some flu medicine at the moment, or if my doctor prescribes it, I have to pay for it. Now, I can afford to pay for it. There are many people who aren't in that fortunate position, and when they go to pay for it, it's a huge chunk of their disposable income. What I understood from what Dr. Crisp was saying is it'd be a little bit like what happens in the UK, where you have a national health system. If you want to go to a GP employed by the state, you wait. So as an entrepreneur, it doesn't make sense. So you buy yourself access to private care, which means, yes, you are going to continue with a medical aid, but presumably the medical aid costs will be lower because a lot of what you're paying on medical aid for today, you'll be able to get from the national health system. That's kind of the understanding that I had. It isn't an either or situation, but that there would be a reduction in the wastage, and we would not lose that right to go to private hospitals or to go to private doctors.
Yeah, look, there are a number of aspects around that, Alec. First, the impact on the private sector. The assumption is just the hospitals will stay behind and be there. They won't disinvest. Because remember what the NHI are saying is that they're going to determine the reimbursement rates, the level that all private providers. So if it's below, so it's price controls essentially what it's saying. Now, if that gets set below a level of which those entities can make a reasonable level of return, they'll just disinvest. So the hospital won't be there to actually deliver this care that they're talking about. The same for doctors in terms of if they need to run a practice. It gets a bit more complex. Even we talk about the certificate of need, which is a parallel piece of legislation that sits under the National Health Act, which is now not only going to, so the National Health Insurance will determine the level of reimbursement, and the certificate of need will now determine where the private providers can practice, what they can practice. So it becomes quite restrictive to the extent that you may well have large disinvestment institutional service providers or immigration from the individuals. So the assumption that the doctors are all going to be there after NHI is, again, a very big assumption that hasn't been tested. The aspect of waste as well, I recall, I think I'm correct, but Dr. Crisp said that they could reduce the wastage in the private sector by 50%. Now, that's a massive assumption based on no studies. There's been, I don't know where he would get that number from, but it's a very, very, to make such a statement, I'd really love to know where and how he comes to a calculation of taking or reducing costs in the private sector by 50%. No one else has been able to do it, so I'd be very curious as to, and by what mechanism is it going to reduce? Is it the assumption now that all these providers are making so much money they don't know what to do with it, and they're making 50% gross profits that we can now, bring down? It just doesn't bear out. If you actually look at the numbers, it doesn't bear out. I mean, hospitals themselves, they're not struggling, but they certainly don't make the kind of returns that they were making some time ago. The medical aids have managed to squeeze a lot of pricing out from them. So this notion that there's this massive amount of waste in the private sector just doesn't bear scrutiny, and there's no evidence for it. I'd like to see it. I'm not saying it's all rosy, that there are no problems there. There are issues that need to be dealt with. And we had the health market inquiry that did an enormous amount of work. And that's just sitting there gathering dust, and nothing's happening in terms of what could be done there, which kind of brings me up to a point of the one thing about the NHI that really sort of drives me quite nuts is that there are so many good things we could be doing in both the private and public, but everything gets pushed aside to say, well, NHI is going to fix it all. And so nothing happens. So we're in a policy sort of, even not a vacuum, a sort of sense of limbo, nothing happening.
I really liked what Ryan Noach told us, where he said that there needs to be engagement, there needs to be discussion, there needs to be a joint solution found. And I saw that in the Filipino model, the Indonesian model. There's a lot of public-private partnership there. 65% of the hospitals are privately owned. And the doctors they get well paid. They get properly reimbursed over there. So there's a lot more discussion. It just appears certainly from the feedback that I'm getting from you and from Dr. Noach and generally from the business community who are very up in arms about this, that there doesn't seem to have been much discussion when the call for input is made. Not a heck of a lot of notice is taken of it. Might that be a beginning of finding a solution for us?
Yeah, and I think 100% spot on. There's been this certainly the policy process has not really sort of felt that there was participatory democracy being practiced throughout this thing. All the proposals that were given to the Health Portfolio Committee, of which were more than 100, from various players, including ourselves, not a single aspect was brought in as a change to the bill from what it was. There was a green paper in 2011 and there were 2 subsequent white papers. Nothing was changed, absolutely nothing. So, it seems like it was just an ideological framework that was put together and it was just going to be forced through no matter what without sort of any considerations. The medical fraternity as well, if the NHI is hanging on to the private sector, the providers in the private sector will be there to deliver care through finance through the NHI, and that they will be able to bolster and improve the delivery capacity of for the entire country. But they haven't been engaged at all. If you think about when Anur and Bevan built the National Health Service in the UK after the Second World War, it was a process of about 3 years, and he worked like a Trojan putting that together. But the thing nearly collapsed because the doctors refused to partake in it. They also had all these concerns, and it only actually succeeded after engagement with the equivalent of their medical board, that Bevan then gave the doctors representation on the NHS, and that then swung them over and that brought them on board. So there was trade-offs obviously that had to be made in that process, but it understood quite clearly that unless you have a willing and able medical fraternity, you don't have a health system. You have to look after those are the core people that deliver the healthcare, and not even the public sector providers I think have been engaged really. So I don't think it's just in terms of the private sector. The provinces, they're much of their functionality and then its prices are going to be removed as well. And it raises concern, but some sort of possibility that I think that this bill might run into trouble in the National Council of Provinces. I don't think all the premiers are going to be that happy about the progress of this bill. And I'm speculating that I don't have any evidence for that. But we'll obviously see as it progresses in the next year.
And we haven't even started on the state capture, plundering of resources, incompetence, cadre deployment, many obstacles to overcome. But perhaps the best place to start is proper engagement. Michael Settas is the chairman of the Free Market Foundation's Health Policy Unit, and I'm Alec Hogg from biznews.com.